Webinar. We have an exciting program today. I'm Matt Brengman, and I'm joined today by a co-chair, Venkat Modukuru, and our esteemed faculty, Doctors Altieri, Hooper, and Nimeri. And we have great talks today. Would encourage lots of activity in the chat. We'll be careful to try to answer as many of the questions from the chat as possible. The format's going to be sort of 10 to 13-minute talks with a few minutes discussion after each, and then a few minutes of wrap-up. We're going to begin our talks today with Dr. Altieri from the University of Pennsylvania. She is the assistant professor of surgery and section chief of GI surgery at the Pennsylvania Hospital. She has presented at many national meetings and peer-reviewed publications. She's very active in multiple organizations, including leadership positions in the American College of Surgeons, SAGES, the Society for Surgery of the Alimentary Tract, and the Association of Women Surgeons. And we welcome her today to present on limb lengths and gastric bypass.
Thank you, Dr. Brengman, and thank you, Dr. Modukuru, for this opportunity. And I'm very, very excited. As I was talking to Dr. Nimeri and Dr. Hooper, I don't usually interact with a lot of fellows, so this is a great opportunity to kind of give back to the fellows as well. So I'm going to start with the limb lengths and the Roux-en-Y gastric bypass. And I do have some disclosure, but nothing relevant to this talk. But one of the disclosure that I wanted to kind of bring up is my experience. I was a fellow at Washington St. Louis, and I trained with mostly one of the main surgeons there, one of the elderly surgeons, so to speak. And the way that I was trained is actually via a retrocolic retrogastric with an EEA. And we did change our limb lengths, but I did change this after I started my practice, and now I'm anticolic, antigastric. And I have a standard length for 150 elementary and 75 for BP length. So I just wanted to kind of share this with you. And so the aims of my talk today are to describe the history of Roux-en-Y gastric bypass very briefly, discuss some of the common limb lengths, and also review of the literature. Since I'm the first talk, I wanted to kind of briefly go over the landscape of bariatric surgery, very, very briefly, 30 seconds. So as of 2022, I'm very curious to see what the 2023 and 2024 numbers are going to be. But we had about 280,000 procedures done in the United States in the Center of Excellence places. The sleeve continues to be the number one. The bypass, though, is the second most commonly performed procedure. And I wanted to go towards the revisions as well, because those probably are mostly, sleeve to a bypass or a band to a bypass. And so we do have a lot of patients that are going around with that anatomy. The bands continues to be low, and then newer procedures as well are involving. And then, of course, the BPDDS, ADS, and anastomosis, the numbers are there as well. And my colleagues are going to discuss those in a little bit. And so one thing I also like to talk to my patients about, and I think it's always great, and the band here is a historic procedure at this point. You can probably interface the GLP-1 like tirzepatide with that total weight loss. But when I talk to my patients, I do like to tell them about what expectations they should have in terms of weight loss. Sleeve gastrectomy is about 30%, gastric bypass 35, BPDDS 40, and the GLP-1 is about 20 to maybe a little bit less than 20, but something to consider. And the bypass used to be the most commonly performed procedure in the early 2000s, but afterwards, in about 2012 to 2013, the sleeve kind of took over and has been, so to speak, the king of bariatric surgery, even though I consider the gold standard still to be the Roux-en-Y gastric bypass, but now it's the secondly most commonly performed procedure. So briefly wanted to go over the history, and you probably have heard of the jejunal bypass, and that was mostly in the 1940s, 1960s, which was done by Kremen and Linner, and that wasn't a very good procedure in terms of a lot of complication, a lot of malabsorption, and fell out of favor. In 1967, a Swiss surgeon, Dr. Cesar Roux, actually created the bypass, but it was mostly as a gastrointestinal procedure. It was for peptic ulcer disease, actually. And then the key figures was Dr. Masons and Dr. Ito, who actually more pushed the surgery towards a bariatric surgery, or weight loss surgery, so to speak. And originally, that was a loop bypass with a larger stomach, like larger pouch, which led to a lot of bile acid reflux. And finally, around 1977, Griffin actually described his experience, and that was the Roux-en-Y configuration now, that switched from that loop bypass to what we kind of know of the Roux-en-Y configuration today. And the first laparoscopic Roux-en-Y gastric bypass was actually done in 1994, again with the EA, and that was actually my experience as well back in 2018. So had to change. And so a little bit of terms. I wanted to kind of bring this up, and I don't know if you can see my pointer. Can you see my pointer? Oh, not really. Well,
we can see it.
Yeah, thank you. Okay, so here is the pouch, which is designated by P, then the alimentary limb, which is A, the BP limb, which kind of joins the alimentary limb, and then the common channel. And I wanted to also bring this other term, which is the total alimentary limb with the TOL, which a lot of the papers actually describe, and that's the Roux limb, which is the alimentary limb and the common channel. So this total alimentary limb. And so why is this a debate, right? Like why? Well, it's because the human small bowel actually can be extremely variable. Any ranges between like 3 meters to 9 meters, but in some reports, they have been reportedly a small bowel of 1.6 meters and all the way up to 15 meters. So very, very variable. And the study in 1974 actually did this human cadavers and examined the bowel. And the average length was about 3.5, and averages between 2.9 to 4.3 meters of small bowel. And and the other issue is that we are not really exact with our measurements either. This is a study that was published in 2008, was presented on the ASMBS meeting in 2007. It was a survey of 250 ASMBS members, surgeons. And you can see there only 7% actually accurately kind of examine. It's like, the way that we do this is through measurement with our instruments. And we're like, well, it's, like our average BP limb is 48, average rule is 114, but can we really tell if only 7% actually use umbilical tape or suture to measure? This is another study, which is a more global study. And another concern as well here is that less than 20%, so 18% measured the entire length of the small bowel. So if you had somebody who has a shorter bowel length, the common channel might be a little bit shorter, and I'll go over why that is important. Although 18% measured the entire length of the small bowel, 87 actually used the constant length for BP and elementary limb. The BP was 76 to 100, elementary was 126 to 150, and they changed this based on BMI, diabetes status, or an age. And so in my experience, actually, when I was a fellow, we changed this based on BMI, but none of the other factors. So let's go over some of the data in terms of the alimentary limb. And there have been a lot of studies done. This is something that was published in 2005, 50 patients. And they compared a short limb, which is a 50 centimeter BP versus 100 elementary, versus a long limb, which is 100 BP, 150 elementary. And they saw that there was no difference actually in terms of weight loss, and also no difference in terms of significant nutritional deficiencies. And they followed these patients up to 12 months. But they noticed that internal hernia rates were actually significantly higher for the longer limb in terms of that configuration. This is another study that was published in 2002. Again, 4 groups, and they differed in terms of BMI. So the lower BMI versus higher BMI. And the elementary limb went from 75 to 150 in the BMI less than 50. Above BMI 50 was either 150 versus 250, so all the way up to 250. And they followed up the patients They had a pretty good follow-up up to 24 months, but they actually kind of followed them all the way up to 36 months as well. And they again saw that there was no difference in mean weight loss, change in BMI, and percent excess weight loss over the time. But when they looked into those patients that achieved that 50% excess weight loss, they saw that even though in the lower BMI didn't matter, the length of in the higher BMI, 150 versus 250, the 250 centimeter elementary limb got faster to that 50% at 18 months. But when they examined that at 24 and 36 months, they actually didn't see any difference, and they kind of reported that probably because of their small sample size and people that were actually still in the study. Another study kind of examining the standard versus distal Roux-en-Y gastric bypass in 113 patients, BMI 50 to 60. The standard elementary limb was 150, but now what differed here was the common channel. So it was a different variable elementary limb, but the common channel was 150 centimeters. So it was pretty short. And then they had similarly standardized their BP limb was 50 centimeters and their gastric pouch was actually 25 centimeters. And what they saw here, and again, kind of very interesting, was that the body mass index over time up to 2 years didn't really matter. But what mattered was, or what changed was the reduction in fasting glucose levels and hemoglobin A1C were greater after that distal gastric bypass, so the shorter common channel. And then malabsorption, malnutrition was higher. Secondly, hyperparathyroidism, looser stools were significantly higher after the distal gastric bypass. One patient developed liver failure, and 2 patients actually had to be revised, meaning their common channel had to be elongated because of protein caloric malnutrition. Oh, can I? It's weird. Okay. I'm going to skip this one. So another study, the Ducati trial, randomized 222 patients in 2 groups, so a total of 444 patients. And then they examined the standard, which was basically the BP limb 60, Roux limb 150, and the common chain being variable versus a very long Roux-en-Y gastric bypass. Which is the BP was 60, the Roux or the elementary limb was variable, but the common channel was only 100 centimeters. And what they found was, again, in the very long Roux-en-Y gastric bypass, the excess and the total weight loss was higher in that group compared to the standard, but they also had higher risk of complications. Revision for malabsorption was higher in that risk, and the resolution of type 2 diabetes was also higher. So what I wanted to just kind of, make sure that if you have to bring or take something out of this talk is that the elementary limb, even all the way up to 250 centimeters, that doesn't matter. And what matters is the common channel and how much of that do you have left, which can lead to increased weight loss. However, it can also lead to increased protein and nutritional malabsorption. So the biliopancreatic limb, again, that's another discussion and debate here, but I feel like there's a little bit more literature on it as well. And again, it's very similar to the common channel. This is a study published in 2014, 187 patients. They compared a 200 centimeter BP limb and a 60 centimeter elementary limb versus a 150 elementary limb and a 60 centimeter BP limb. So the 200 versus 60 BP, like, long versus short BP limb. They did follow up the patients for 2 years. And again, in the longer BP limb, there was a higher excess weight loss at 2 years that persisted actually up to 7 years. But there was a higher incidence of anemia and vitamin D deficiency. Another study, more recent, 146 patients. Again, the long gastric bypass versus the short gastric bypass. The BP limb here is 150 versus 75 versus 75 and 150. And again, the weight loss was better in the higher weight in the longer BP limb, but didn't actually that didn't matter at 4 years afterwards. So again, for BP limbs, longer length BP limbs can lead to more weight loss, but it can also lead to more malabsorption, malnutrition. And I wanted to go over this. Dr. Nimeri, actually, I think he's going to talk, but just briefly kind of talk about like what is type 1 versus type 2 distalization. Type 1 was Dr. Sugarman actually described this. Type 2 was Brolin, I believe. But the interesting part, honestly, like a lot of the literature, it's almost like the Wild Wild West in a way, because a lot of people are doing different things. And so there were so many studies, and the studies were literally like sometimes teens of patients to 20, description of 20 cases. The larger study was come out. But so what is type 1? Type 1 is shortening of the common channel through elongation of the BP limb and without changing the elementary limb. Versus type 2, which is shortening of the common through elongation of the elementary limb and without changing the BP limb length. So those are the two types, and Dr. Nimeri can give a little bit of a more of a discussion there. This was the largest probably study that I've seen. Going through reviewing the literature, it was 65 patients, and I think they did the type 1 elongation or revision, and it was a banded gastric bypass, and they moved the elementary limb to reduce the common channel by 50%. And again, BMI lowered, but that was in light of also developing significant protein malnutrition and also requiring surgical intervention to elongate the common channel because of that issue. I wanted to bring this article as well. This is a great review article. If you have the chance to actually go over it and read it, it's pretty extensive, and it discusses a lot of more literature in there that I could fit in, 12, 13 minutes. But again, elementary limb doesn't matter. 250 with fit BP still has minimal additional weight loss, and is the short common channel that may result in improved weight loss, but associated with malabsorption, malnutrition. The lengthening of the BP limb up to 200 centimeters with or without shortening of the elementary, again, can lead to greater long-term weight loss and improved glycemic control, but increased risk of micronutrient deficiency, the type 1 distalization. And one thing that comes up with this is that, especially for the distalization, for the Roux-en-Y as a revisional procedure, you should have a pretty extensive discussion with your patients, and they should be adhering to aggressive vitamin supplementation. So in summary, variability exists. And one thing for me at least is that I will start, and I've been actually for my revisions, I have been pretty good in terms of measuring my common channels, but I have to be honest, for a primary Roux-en-Y gastric bypass, I rarely do. Every once in a while I'll kind of like go over, but I won't like actually measure a lot of it. But something for me as well, and probably hopefully you. And especially for revisions, patients should be advised and educated on follow-up. So thank you. I am going to stop sharing and looking forward to the discussion.
That was great. Thank you for your comprehensive review. I'd say I've been doing bypass since 2001, and my BP limb is definitely longer now, and I think in my my anecdata is that works better, but you're trying to prove me wrong, but I just it seems, and I think most people feel that most people do it longer, they make longer BP limbs, they don't pay as much attention to the alimentary limb. What do you?
How long is your BP limb now?
I don't use a measuring tape so much. It's probably between 100 and 125, so it's not super long, but it's definitely not the classic. I just did a revision on somebody yesterday who'd had their open gastric bypass in 2001. They had a classic operation: 25 centimeter BP limb, 50 centimeter retrocolic, anti-gastric, undivided gastric bypass. And so hard to know, but we're definitely doing longer now, and I think some of our techniques, definitely the omega loop technique, allows you to do that a lot more easily than maybe some other techniques.
I have a follow-up question for you, Dr. Brengman. Did you excise that roux limb when you did that revision, or did you put it back in continuity and move your move both anastomoses, or did you cut out that 50 to make your elementary limb a little bit longer and your BP longer?
In that case, I was actually doing a pouch revision, so I didn't have to worry about the limbs, but I do a type 1 distalization when I do a distalization, so it's just taking off the Roux limb. In that case, though, that'd be a little harder because you're still talking about a Roux limb that's pretty short. Only 50 centimeters. You could end up with some significant bile reflux. We see, I'm sure everybody around this table has seen that before too. So just got to be a little careful about that when they come in real short like that. But what would you do?
Same. In that instance, I would definitely measure all of the bowel and then make sure I've got that at minimum 150 centimeters of common channel. If I don't have that, then I'm going to measure and do that percentage like Hess kind of talks about, making sure that, at least 40% is your alimentary limb. And that's really for duodenal switch where you have a pyloric valve in play. So I try to make it longer. There's another ASMBS article, and I can't think of who is on that. Dr. Nimeri probably knows off the top of his head, or Dr. Altieri too, that is talking about the percentage of lengths to keep in a distalization.
The only other comment I would say is on the FOBI paper with the banded gastric bypass with the distalization. That's kind of a recipe for disaster, right? So that's somebody who can't eat typically and won't be able to eat 10 years from now. And then you're also doing significant malabsorption. I think that those numbers of revision are super, super high. And I think reflects that severe restriction. And I think I heard Dr. Nimeri say one time, don't do both. Don't do a pouch revision and a distalization at the same time because that's problematic.
I actually do that if the pouch is big. But if the pouch is not big, I agree with you. And I totally agree with you that banding the pouch in the FOBI article is probably more problematic. But many times, like the case you described, Matt, you go after an open bypass and the pouch extremely large. So if you just distalize without making the size of the pouch appropriate, I think you will not see the effects of distalization. But I agree, you don't want to make the pouch too small.
Great. Well, excellent talk, excellent discussion. I think Dr. Modukuru is going to introduce our next speaker.
Thank you, Dr. Brengman. Good evening, Dr. Hooper. Thank you for joining us today. So Dr. Hooper did an undergrad from the University of Oklahoma, and then, the residency from Rush, did the fellowship from Tufts, and she's board certified. She also has the focus practice designation by the American Board of Surgery. She's also a diplomate of the American Board of Obesity Medicine. She was a member of the MBSQIP in the committee, and she's now in Dallas at the Medical City Healthcare Center. She's going to talk to us about the duodenal switch and the nuances of limb lengths for primary and revisional procedures.
Thank you very much for that nice introduction, and thank you for joining us from India and being here so bright and early. I don't think I see the sun coming up behind you in the windows yet, but maybe as we continue tonight. So it's a privilege to talk a little bit about limb lengths for duodenal switch. Some of the things that Dr. Altieri was talking about in making sure you have enough length. These are some of the reasons I really like duodenal switch for my patients, especially here in Texas. We have a lot of people who suffer from obesity with high BMIs above 50 or lower and significant diabetes. And so this can be a great intervention for those patients. One of the things we're doing with duodenal switch is we're counting from the bottom. So we know how long that common channel is. My disclosures, I do speak on behalf of Intuitive at times. I am not speaking on their behalf this evening. I want to show just a couple of videos while I'm talking to keep you engaged and entertained. This is a sped up video, and here I'm actually measuring that top left corner. That was the ileal anastomosis. So I'm measuring backwards all the way up to the ligament of Treitz. And this is just a nice hand over hand technique to demonstrate a an approximation of the small bowel, moving that in a large counterclockwise direction towards the patient's right lower quadrant, as I'm ultimately making the moves back to the ligament of Treitz. You can start to see the transverse colon appearing in the top left of the screen. That is the sleeved gastrectomy. So this was a patient who was suffering from protein calorie malnutrition and had pretty significant lower extremity edema, and some other, even had a DVT from edema in the legs and distal kind of obstruction, if you will. So here I'm marking where I've now made it to 300 so that I can do that proximalization instead of a distalization, where I'm going to move that alimentary or Roux limb to make a longer common channel. So I'm going to pause there. I always think of duodenal switch as the Goldilocks, or we're walking a line. We're trying to be somewhere between giving patients shortcut, which is bad, and helping them maintain weight loss and also maintain nutritional outcomes. So, you know, with shortcut, we're going to see diarrhea, some protein malnutrition, steatorrhea, increased rates of cholelithiasis and nephrolithiasis, and micronutrient deficiencies. We can see all of that with shortcut as well. So we need to find this space for each patient that is greater than shortcut, where they need IV nutrients or revision to a longer common channel, and enough malabsorption that they maintain their weight loss long term. So there are different ways that we can measure and think about the lengths of the small bowel as we are measuring it. We can eyeball it. We can use a known length like an umbilical tape or a piece of suture. You can mark your instruments with a permanent marking pin or wrap them. Being careful that you don't leave any of those markings on your instruments behind, like I've seen steri-strips used, those might come off. Or you can use like a fixed instrument, like placing a ruler inside the abdomen. All of these have some potentials for risks. This is the not sped up video measuring the small bowel with umbilical tape. And this is my video. I try to just lay that pretty carefully next to the bowel without being too precious with it, if you will. And in general, I make a 150 centimeter common channel and a 150 centimeter Roux limb. And that comes from a couple of different places, knowing that shortcut syndrome tends to show up with 80 centimeters of small bowel and an ileocecal valve. And then some of it from the data for SADI that, you know, a 300 centimeter total alimentary limb works pretty well. So if I split that, I shouldn't get bile reflux, and I should further decrease some of that absorption. Okay, the videos are coming through. Thanks very much. Now I have a chat box in my way. Okay, sorry. Need the chat to go away. Okay, so this is a paper that was presented by a group out of Germany in 2021 at IFSO, where they were looking at the comparison of conventional methods for bowel length versus using a computer model. Not surprisingly, a computer model to measure is better than our naked eye. It turns out our visual judgment is actually the least accurate. A pre-measured tape is decent, or instrument markings. But with any of these findings, with any of these implements or tools, you know, we're going to see best accuracy with a computer. A pre-measured tape is actually second, visual inspection at third, and then an instrument marking is fourth. Like in that first video, I was using robotic instruments, and that wrist is turned. So if you're not turning the wrist the same way each time, you can have an error every time you measure. And the further you're going, the more you're going to carry that error through potentially. Number of bowel grafts, visualization is going to be the least. number of, or measurement time, visual inspection is the least. So in general, the recommendation was from this paper is that a pre-measured tape is going to give you the best accuracy with the kind of middle of the road measurement time, and bowel grasps are going to be a few more. So eyeballs least reliable. This can compound your error as time goes on. If every time you think it's 5 centimeters, it's only 3, you're going to leave yourself with a shorter limb length. Thread or umbilical tape, it's a little bit more reliable, a little bit slower. You're going to handle the bowel a little more. You can use that same length throughout. I actually use my umbilical tape to mark things a little bit later. And then as time goes on, we're going to see more and more aids in the operating room with the different types of instruments that we use that are going to help us improve this accuracy. So what does the data say? Well, there's actually a pretty recent article that was just published online in December from Dr. Ganem, Dr. Teixeira, a number of physicians that looked at the effective limb length on weight loss outcomes. And this is 2 centers. And the basics on this are the common channel, and I'm going to look at my numbers so I don't quote this wrong. It's kind of behind my head on my screen. There were 720 patients, and 60 of the patients were in the group with a 100 centimeter common channel and a 150 centimeter Roux limb. So that's number 1. They had 44% total body weight loss, but complications were listed at 28.5%. Of that, 5% were nutritional deficiencies based on Aspen criteria, and they looked at that at 2 years out. The next group was the 125 centimeter common channel, 125 centimeter Roux limb, and just a little bit less weight loss, 40.6%. But the complications dropped down to about 12.5% and 1% for nutritional deficiencies. This also had the largest group at 596 and can reflect some changes in practice patterns over time. And then the third group had 64 patients with a 150 centimeter Roux limb, a 150 centimeter common channel, and the weight loss was significantly less, again at 35.9% total body weight loss. A lower complication rate again at 7%, and then a 4.7% nutritional deficiency. So it's very interesting that the nutritional deficiencies were very similar between the 150 and the 100 on the common channel. I think what this really shows us is that there are changes based on the length of that common channel, and that those do make a significant difference in the long-term weight loss outcomes for patients. So when they did all of the data extrapolation, for every 10 centimeters decrease in, wait, let me read this right. There's too many negatives here. There's a 1.8% decrease in weight loss for every 10 centimeters of increase in common channel. So 100, 110, going to drop your weight loss by 1.8%. So that does become significant looking at long-term outcomes. It's always that balance between those two findings. There's also a book that's out called Duodenal Switch and its Derivatives in Bariatric and Metabolic Surgery, Comprehensive Guide. Mine is recently found. It's still in the mail on its way to me. I wanted to briefly touch on revisions as well. So revisions with duodenal switch, that group of 5% with nutritional deficiencies, or more commonly, someone who had a sleeve and is experiencing weight gain, who needs to go from a sleeve to a duodenal switch. Think about, we've basically staged a duodenal switch, but over years instead of over a few months for someone. So the goal for someone with weight gain is going to be shorten the common channel. I think those principles still hold true. You need at least 100 centimeters. I wouldn't go any shorter than that. And personally, I'd be more likely to err on the side of length. The opportunities for someone who doesn't quite get all the way to their weight loss, there are certainly, you can shorten the common channel. We can use medication adjuncts. There are all kinds of things we can do for people. On the other side of revision, where we might be looking at, oh, let's go back one more for weight gain and sleeve to duodenal switch revision. Sleeves come in all sizes, and the original papers on duodenal switch were often cited with a bougie of a 50 French bougie. Most of us are not using that size on our primary sleeves, which means while we may see a little bit of dilation of a sleeve, we're probably not getting that long-term size back that a early duodenal switch had. And so while we want to give more malabsorption to our patients to help them maintain weight loss long-term, we have to be mindful that not all sleeves are created equal. And then when we look at protein calorie malnutrition or micronutrient deficiencies or fat soluble vitamin deficiencies, or a patient with fat soluble vitamin deficiencies who's having 12 loose bowel movements a day that are uncontrolled, this is someone who needs a longer common channel. And this is kind of the anti-type 1 distalization. So generally, I will amputate the roux and rejoin that on what was the biliopancreatic limb in a more proximal direction from that first video going back. So I have about a 300 centimeter common channel. And I base that data kind of on what we see that works well with SADI. Recently did a revision for a patient who had very severe protein calorie malnutrition, but also chooses to continue to eat gummy bears and Gushers fruit snacks as her primary intake, despite multiple hours and hours of counseling. And so that's someone that, in our practice, we really have concerns about long-term follow-up nutritional deficiencies. So we put her small bowel really back in continuity, and then did a more proximal SADI, making that long enough on the BP side that if we need to amputate that in the future for reflux, we can move that down without it being super short, like those early bypasses with the 30 centimeter biliopancreatic limb. So in closing, duodenal switch, the data says not a lot, but in general, the most important thing I would say is that common channel needs to be at least 100 centimeters to reduce the risk of vitamin nutritional deficiencies, protein calorie malnutrition. I think we're going to see this swing between 100 and 150 continue to work back and forth. And I think that has to be in somewhat of flux based on your patient population, follow-up, risks and benefits for each patient as you, in some ways, I think our data is going to get a little bit worse as we individualize some things for patients. So as a society of bariatric surgeons, I do think we need to continue to pool our data so that we can get as many like patients together to look at those outcomes. Happy to answer any questions.
Great. Excellent talk, Liz. Appreciate it. First, I got to ask, how long is that umbilical tape?
I use a 50 centimeter umbilical tape. So I move it 3 times for my 150 common, and then I leave a silk stitch. And then I move it 3 times for my roux limb and put a silk stitch. And then I'll actually take a little piece of that umbilical tape and put it just on the downside of where I'm going to make my duodenal ileostomy. And I'll lift that umbo tape as a handle so I'm not grasping that bowel right above where I'm going to make my anastomosis.
Nice. Nice. Let's see. Looking at chat. There's no chat questions. Any questions from our moderators?
I'm just curious, Liz, in terms of, you mentioned, like no sleeves are created equal, and sometimes we have the, like really like long bougie, and I can't remember who it was, but the they came to one of our meetings for a Pennsylvania chapter meeting about a couple years ago, and they were talking about re-sleeving the sleeve. I just wanted to see what your opinion on that was.
I generally don't re-sleeve. And I talk to patients about that quite a bit because they all want that feeling of significant restriction. And the conversation I'm usually having is, this operation works completely different than your sleeve worked. The goal of this operation is malabsorption, and it is going to change your relationship with food forever. So if you're 40 and for 35 years, since you were really in charge of what went on your plate, or 30 years, you've always been limit, limit, limit. Now I'm going to tell you, I need you to eat. I need you to get enough protein. Instead of limits, we're going to be setting goals. And people usually respond to that pretty well. I have pretty good weight loss for people that have gone from sleeve to duodenal switch. I do a screening upper GI on patients. So if they truly had a very large fundus, or if it looked like they had a mini sleeve gastrectomy where the fundus was never touched, that's someone I probably would sleeve. When I'm doing a primary duodenal switch, I use the same 40 French Visi-G I use on a primary sleeve. I do stay maybe a little eyeball thought away from that bougie a little bit more than on my regular sleeves. And I think with in practice over time, I probably make my regular sleeves a little bit bigger than I did when I first started also.
We have a question from the audience, from Dr. Matar, who wants our opinion on severe malnutrition in a patient who had a Roux-en-Y gastric bypass. Would we reverse it or redo with change of limb lengths for someone with a Roux-en-Y in the past and severe malnutrition?
Sure, I can take that question. So for someone like that, you first want to make sure their albumin is at least over 3. So we typically put them on TPN, and then we take them to surgery after having done at least an upper GI or an endoscopy to make sure there's no stricture or something else. And then in surgery, we move the Roux limb up to make sure most of these patients have a short total elementary limb length. So we make sure they have at least 300 centimeters of common channel and 100 to 150 of Roux limb. And most of them that improves things.
Yeah, I'd agree with that. And getting nutritional repletion is just so critical in that group. My first introduction to that was a patient who was in the ICU who nearly died from like a mosquito bite because of her whole body anasarca, because her albumin was 1, and then nursing her back to health to be able to do that revision. It's just a long process. It takes a long time. That's a 1-year project basically. That albumin doesn't recover quickly for sure.
I was going to answer this question real quick. Yes. In the chat. When do you decide to do a sleeve revision to a SADI or a DS? Hi, Dr. Bassa. My kind of workup for someone with a sleeve to DS, I always do an upper GI, so I kind of see the lay of their sleeve and how it's emptying. I generally do an EGD as well, make sure there's no Barrett's, no esophagitis that would push us somewhere towards bypass potentially. On that EGD, looking for bile reflux in a sleeve. So if I see bile reflux in a sleeve, that's somebody I'm going to recommend traditional duodenal switch to from the very beginning. Somebody who has weight gain, but none of those other concerns, I think SADI is a very reasonable option. Sleeve to DS with a couple of years in between, you will see slower weight loss and not as much as a DS that's all together. So I think it kind of depends on the patient's expectations, how you feel their follow-up is going to be. If area covers a wide space and you lose more patients, SADI might be a little bit lower rate of vitamin deficiencies, and something that sometimes I think we have to think of. And then this other question, thoughts on measuring bowel length of a dynamic muscle, i.e. the small intestine. Is it possible to truly achieve standard measurement? Any technique to ensure your 150 is actually 150? That's exactly why I do 150 and not 100, so that I have a little wiggle room. I was surprised by this paper that came out in December that I may be really significantly altering weight loss. So I probably will shorten that to about 125, but on the few I've been back for with, if I'm taking out someone's gallbladder and looking at internal hernia spaces, I always start distal. And so I like to kind of eyeball measure it and see if I get to about 150. And I'm usually between 135 to 150 eyeball at that point. But it's not
great.
perfect.
Awesome. We'll move on to our last speaker so we get in under time. Our next speaker is Dr. Abdelrahman Nimeri, who is the chief of bariatric surgery at Brengman Women's Hospital, formerly in North Carolina, and well known from his work in the research committee on the mechanics of gastric bypass and limb lengths. He's well published on that, and we look forward to his talk on distalization and OAGB.
Thank you. Thank you so much, Matt, for the kind introduction and the invitation, and thank you, Venkat. So this is my disclosure slide. You can see that 60% of what I do is Roux-en-Y gastric bypass, and you can see my financial disclosure at the top. So I'm going to try to cover three things in the next 10 minutes. Why the variability in small bowel length that was mentioned by Maria earlier is one of the reasons that we have different outcomes in both Roux-en-Y and one anastomosis gastric bypass. And what's in common between OAGB, DS, SADI, and type 1 distalization, and how much total alimentary limb length you need to prevent protein calorie malnutrition when you revise in Roux-en-Y and one anastomosis. And then finally, just try to briefly talk about the pouch size and how it affects outcomes. So we've come full circle. All our procedures, both gastric bypass and DS, were done in a loop configuration first. Then they became Roux-en-Y for a very long time, and now we do both in a loop configuration because our understanding of how they work has really changed. And Dr. Altieri earlier mentioned the variability in small bowel length. And the only thing that you could bank on is how tall is the patient. If you have a patient who's very short, maybe their bowel is short as well. And you need to recognize that 2 to 3% of patients might have less than 4 meters of bowel, and 5 to 15% might have more than 800. And I'm going to try in the next few slides to explain why is that important and what difference does that actually make. So this is the review that Dr. Altieri talked about earlier. I've had the privilege of being part of it. The review shows that there's no consensus in the optimal limb length in the bariatric community. Surgeons in the US make a shorter BP limb compared to international surgeons. And I'll talk to you in a little bit how that makes a difference. But I think first I want to just cover something that's important that for all of us to recognize. If you look on the left, Roux-en-Y and one anastomosis gastric bypass have a variable common channel every time we do them. And BPD and DS on the right have a variable biliopancreatic limb every time we do them. And surgeons who perform Roux-en-Y or one anastomosis bypass do not measure the common channel. And surgeons who do SADI and DS do not measure the biliopancreatic limb. So for the purpose of this talk, most surgeons, including myself, when we do Roux-en-Y, I rarely do one anastomosis, we do not know the total alimentary limb length in our patients. And this is important. The second thing that's also important, let's see here, is that how do we measure? I mean, Maria told you that less than 20% of people measure, and you saw one way of measuring. This is the way I measure in the OR. Yes, it's not perfect, but at least it's a way. So if there's one thing to take from this talk, don't measure visually. But if you compare on the left SADI then followed by one anastomosis, Roux-en-Y, and then distalization, you will notice one thing is that in SADI, we don't know the BP limb length, and in DS also, we don't know the BP limb length. Whenever we do one anastomosis, we don't know the common channel. So whenever you do revisions, you need to measure all the limbs. It's not enough to, even when I do type 1 distalization, yes, it's a Roux limb of 100 and a common channel of 300, but if the patient has 10 meters of bowel, I'm not going to leave all the bowel, the rest of the bowel as BP limb. I'm actually going to do percentages. So this is an important thing. So if you look at the variability of small bowel, and let's take 3 patients you're doing today in surgery. They have variable small bowel length that you don't know. And let's imagine the first one, their small bowel length is 700. So if their small bowel length is 700 and you did a Roux-en-Y gastric bypass, they have 650 centimeter of total elementary limb length. And if you did one anastomosis, it's different. If you did SADI or DS, it's different. But if that next patient has 500 centimeters of bowel, you did the same Roux-en-Y gastric bypass, their total elementary limb length is 450. The third patient has 900 centimeters of bowel. You did the same Roux-en-Y gastric bypass measurement, their total elementary limb length is 850. So the changes in the variability could be not because you're doing something different, but because you're not accounting for the variability of small bowel length. So what the procedures I mentioned, one anastomosis, DS, SADI, and type 1 distillation have in common, they have a longer biliopancreatic limb. This is the same review showing that lengthening the Roux limb makes no difference. Lengthening the BP limb up to 200 centimeters leads to better weight loss, better diabetes resolution. But the problem is this can come at the expense of nutritional deficiencies. So again, that same example, looking at BPD, DS, SADI, one anastomosis, and Roux-en-Y, and just focusing on the biliopancreatic limb. You did the first patient, you didn't know what their bowel length was. It's 700, which is the average. That patient, if you did BPD, DS, or SADI, they have 400 to 450 BP limb. If you did one anastomosis, it's 200. If you did Roux-en-Y with a short BP limb, it's that short BP limb. So that's why the patient is going to do better with BPD, DS, and SADI because their BP limb is longer. Now, what if the patient had 500 centimeter of bowel? Again, the BP limb is still longer in BPD, DS, and SADI. And even if they had 900 centimeter of bowel, the BP limb length is still longer in BPD, DS, and SADI. So these procedures, BPD, DS, and SADI, and wound anastomosis, have better weight loss than Roux-en-Y simply because they have a longer biliopancreatic limb. And if we do not account for the variability in small bowel length, we could end up sometimes with recurrent weight gain, suboptimal weight loss, sometimes with malnutrition, depending on the bowel length of the patient. So this is a systematic review of 13 articles showing the point I said earlier. The longer your biliopancreatic limb, the more weight loss you get. And this is a very interesting meta-analysis where they compared only randomized studies where the common channel was known, either because of a longer elementary limb or because of a longer BP limb. Basically, they wanted to show if the common channel is the reason our patients with type 1 distillation lose weight, then if you make the length of the elementary limb long and you keep the same common channel length, or you keep the length of the BP limb long and you keep the same length of the common channel, the patient should be the same. But what they found was it's actually the biliopancreatic limb that matters, not the common channel distance. So in this meta-analysis, clearly total weight loss is longer whenever the biliopancreatic limb is longer, not whenever the Roux limb is longer. So it's not the shorter common channel. So clearly our procedures they're not malabsorptive. Our procedures, and there's many mechanisms that we don't have time today to discuss why a longer BP limb leads to more weight loss. And this is another meta-analysis in diabetes patients, 28 articles showing that if you compare a combination of longer BP limb or Roux limb, the longer the BP limb, the better diabetes resolution there is. And this is now like very, very clear in the literature. And if you look at one anastomosis gastric bypass, because in the Omega trial, when Roux-en-Y gastric bypass was compared to 200 centimeter one anastomosis gastric bypass, that led to significant protein calorie malnutrition. So this is a meta-analysis looking at patients who had a 150 BP limb compared to 200 centimeter BP limb in one anastomosis gastric bypass. 8 studies, and they showed that the longer BPLM leads to better weight loss, but it can come at the rate of micronutrient deficiency, but similar comorbidity remission. And this is the same review I talked about earlier. When you do type 1 distalization, you want to make sure that there's at least 400 centimeter of total elementary limb length. So basically what we do in type 1 distalization, we divide the roux limb on the left, and then we move it down and reconnect it. Where do we connect it? Depends on the total bowel length of the patient. So you have to measure the entire bowel length and then make a decision. And we did a systematic review several years ago with Alice Wong, one of our fellows, and we showed that you need at least 400 centimeter of total elementary limb length, maybe 300 of it should be common channel. And these are all the series that have looked at type 1 distalization. So Sugarman initially in 5 patients did 50 centimeter total common channel. And when he did 50 centimeter common channel, all patients developed protein calorie malnutrition and 2 of the 5 died. All needed to be revised. When he made it 150, more than 40% protein calorie malnutrition. And Higa's group tried 2 iterations of total elementary limb length, 250 to 300 versus 400 to 450, with very different protein calorie malnutrition rate. And there's at least one study showing that you could reach a protein calorie malnutrition of 0%. So clearly there is a sweet spot. We just still don't know. Now let's talk a little bit about the common channel, because it's important to recognize the importance of the common channel. These are 13 studies looking at systematic review, and the shorter your common channel, the more you develop protein calorie malnutrition. For the sake of time, I'm not going to show this study, and I'm just going to try to talk about the pouch in the last 2 minutes. So I showed you that for Roux-en-Y gastric bypass on the left, you need a total elementary limb length of 300. For DS, we've known that 250 works for years. When the group in Spain did SADI with 200 centimeter common channel, they had 8% protein calorie malnutrition. When they made it 250, it dropped to 4%, and that's why they arrived at 300. And I think if you do one anastomosis gastric bypass, maybe you need to make sure the common channel is somewhere between 300 and 400. So I think 350 is a reasonable number. Just to conclude, the size of your pouch is also important. This is an important study from the Scandinavian registry showing that the larger your pouch, the more you develop marginal ulcers. And when we do our pouch, we make sure it takes no more than 3 cartridges. So we measure the lesser curvature, make sure we preserve the neurovascular bundle, including the vagus fibers, and then use no more than 3 cartridges. I think it takes you more than 3 cartridges to make your pouch. That tells you that your pouch is maybe a little larger than it needs to be. And there's been systematic reviews to show that a larger pouch leads to less weight loss and poor diabetes control. And this is another review by ASMBS that shows that you need to make sure your pouch is small and you need to avoid a large pouch. And why is that important? Last study to show. This is a study from Brazil showing that when they took 67 patients with BMI over 50 and did scintigraphy and CT volumetry, they found that the smaller the pouch, the better it empties. So this is similar to what we talk about when we talk about Roux stasis syndrome. You want to make sure your pouch is not big, otherwise it does not empty. So our procedures are neither restrictive or malabsorptive. They cause restriction through a complex mechanism that we don't have the time to discuss today. So in conclusion, our patients feel restriction because of a complex mechanism, not because the procedure is restrictive. They could develop malnutrition, not because our surgery is malabsorptive, because the total elementary limb length was short. And because the small bowel length is variable, you need to test the assumption of the fact that your patient's bowel length is 7 meters. It could be 10, it could be 3.5. And all the procedures that work very well have a longer biliopancreatic limb, but you need to be careful. If you make it too long, it can cause protein calorie malnutrition. And you need to make sure in Roux-en-Y gastric bypass, your pouch is less than 3 cartridges. I'll stop there and happy to take any questions.
Excellent review. There's a lot of numbers there, so I'm having a little trouble wrapping my head around it. So why not total elementary limb length of 400 for everybody?
Because of the size of the stomach. So, and the reason we know this is because when you look at studies where In DS, they use a 34 French bougie. Their outcomes are not the same as if you use a 50 or 60 French bougie, to the point that Elizabeth made earlier, patients cannot eat enough protein. And that's why when we do sleeve for a standalone procedure, the size is smaller than if we do a sleeve for a DS or SADI.
Interesting. Well, amazing review. Thank you very much. In fact, everybody did a great job. We're right up on 8 o'clock, so we'll have to end it here. Any last minute comments or alibis from our speakers?
I think Dr. Nimeri told us make that BP limb is longer, better weight loss with the right size pouch. So I'm glad I don't make 50 centimeter BP limbs anymore on those. And I'm glad I'm also, like Dr. Altieri, not making retrogastric restrocolic anastomoses anymore. I'm glad we've left that behind. I hope most people have.
Awesome. I'm going to go over by 1 minute. There's one more question in the chat. What if you want to do a type 1 distalization, but the roux limb is less than 50 centimeters?
Yeah, so you have to lengthen the roux limb first. So you first have to divide the BP limb and lengthen the roux limb to make it the length you want, typically 100, and then you start your distalization. So you have to add an anastomosis before you start.
Excellent. Perfect. Well, thanks everybody. Doctors Nimeri, Altieri, Hooper, you did an amazing job. Dr. Modukuru, great to see you. Thanks for hanging in there from India. And we'll